We spoke about all sorts of things, but we haven't spoken about clinical trials in acute kidney injury. So I'll try in 20 minutes to cover. And Dr. Marwa actually made my task easier لأنها اتكلمت على كذا حاجة من الحاجات المهمة اللي أنا كنت أتكلم عليها. Clinical trials in acute kidney injury. So we'll talk about fluid therapy very quickly because Marwa already talked about it. We'll talk about renal replacement therapy, when to start it, what type of renal replacement therapy, and how much renal replacement therapy. So we'll not talk about cardiac surgery, we'll talk about fluid overload, and we'll talk about system management at the end. One thing to bear in mind when we start talking about fluid therapy is patients with acute kidney injury, the ones with sepsis, the ones with multiple organ failure, and the ones in the ITU very often tend to be fluid overloaded, have increased permeability of their capillaries, therefore they tend to have easy leakage of fluid from the intravascular to the extravascular space, leading to a tendency to pulmonary congestion, fluid overload in the lung, and pulmonary edema, and acute respiratory distress syndrome. So we have to bear in mind the fact that patients with acute kidney injury can be very sensitive to excess fluid. And as I said before, when you give them an infusion, it stays in the intravascular volume, increases the blood volume expending, and can lead to heart failure as well. So we covered this question, crystalloid or colloid, just to go back to one or two clinical trials. The SAFE trial in intensive care units comparing albumin colloidals infusion to normal saline crystalloid infusion showed no difference in outcome. So whether you give albumin or whether... And this study was after, so this was in 2004. In 2002, there was a worry in some publication that albumin could be harmful. But when they compared this saline, no difference at all. When we come to hydroxyethyl starch, there was this German study in 2010 that implied that hydroxyethyl starch was more beneficial than crystalloid in acute kidney injury, but it turned out that there was issues with sponsorship, possible wrong result, and possible fraudulent result. Basically, the first author, can you hear me at the back? Yeah, the first author may have had links with the manufacturers of HES, the starch, and so on. But when they did a large randomized controlled trial, and always when you look at clinical trial, look at the number of patients on the trial. Is the laser still working? Well, yeah, maybe. Yeah, when you look at the number of patients, it's always important for a clinical trial to be valid that it is well powered, meaning that the sample size is big enough to be able to answer the question you pose. If the sample size is too small, you may get a false negative result because you don't have enough to show the effect, and you can also get a false positive. So, large study, randomized, prospective study over a long period, well, over 90 days in the ITU, no difference in outcomes in terms of survival between saline and starch. But as we said earlier on, when you look at kidney function and serum creatinine, the level was higher in the starch group compared to the saline. And no difference in urine output. Now, if you think about it, this doesn't surprise me. Why? By giving a lot of saline, the serum creatinine may be lower than if you give starch. Why do you think? There may be just simply a dilution effect.
And the starch doesn't do the same dilution?
The starch probably doesn't do the same dilution unless it drags enough fluid from the extravascular compartment into the intravascular compartment. But the saline will intravascular. I don't know, but I'm just wondering if serum creatinine is a good enough marker when you give a lot of fluid and dilute it compared to a hyperosmolar or a colloidal that may not suck as much fluid.
They extrapolated not to use the starch based on this starch.
Yeah. So they concluded, and most people now say, that saline or crystalloid is the optimal fluid replacement therapy in acutely ill patients.
But I think it's very convincing because saline is very cheap.
Yeah.
There is rather high creatinine, and some other studies show osmotic nephropathy after the starch.
Yeah. So I think we're all happy with that. Saline better than colloidals, and saline definitely better than starch. May not be much better than albumin. Then the question is, what type of saline? Would you give chloride-rich or chloride-pure saline? And this was the study comparing, again, this was an open-label study comparing chloride-rich fluid in normal saline compared to chloride-poor Hartmann solution. And they found that there was a lower rate of development of acute kidney injury stage 2 and 3. And there was also less requirement for renal replacement therapy in patients who received low chloride saline compared to high chloride. Now, when you look at something like this, just be careful, because it may be statistically significant as these two are, but the difference may not be clinical significant. So the first message from the first study, make sure when you look at the randomized controlled trial that the sample size is big and the study is well powered and the duration is adequate. For this one, just be careful that this statistically significant difference between these two lines is also clinically significant. And how do you know if a study is clinically significant? There's something called number needed to treat. So the number needed to treat to prevent patients to go into stage 2 and 3 or to go into renal replacement therapy to be significant, let's say, has to be low. The lower, if you treat 10 people and you prevent one from going on dialysis, that is clinically significant. If you have to treat 1,000 to prevent one from going on dialysis, it's not clinically significant, but it might be statistically significant. فدي نقطة تانية. Sorry, I said it last time. Hartmann solution is I don't know the cost, and I'm not quite sure about its post composition, but it's a lower chloride. Why should chloride cause acute kidney injury? And Saddam Hassan, when he was here, explained, if you deliver too much chloride to the loop of Henle, you'll get a lot of chloride delivered to the juxtaglomerular apparatus of the distal convoluted tubule, which in turn will trigger the tubulo-glomerular feedback, which will lead to vasoconstriction of the afferent arteriole and glomerular ischemia. فده المنطق متهيألي to explain why chloride delivery to the distal loop may lead to vasoconstriction.
Might cause some acidosis.
And it might also cause some acidosis, which in turn again can cause vasoconstriction. So this was not a randomized controlled trial. It was an observational study, and there was no difference in morbidity and, well, there was no difference in mortality, but there was a difference in the incidence of people who had stage 2, stage 3, and loss of renal function. I don't know the number needed to treat. Oh, for the number needed to treat, I think most people will say less than 50 is clinically effective. More than 50 or more than 100 then it's, and it also depends on the duration of the study. So if you need more than 100 for 5 years, then it's not worth it. But if you need more than 100 in 90 days, it might be effective. So there's the duration as well. So again, remember, statistic significance and clinical significance. Now, fluid overload, again, Marwa covered that or not. So sensitivity of the patient with acute kidney injury to rapid volume expansion, to excessive volume overload or expansion, leading to multi-organ failure, respiratory failure, and acute respiratory syndrome. And again, if you conservative fluid infusion compared to liberal, generous fluid infusion, and looking at the incidence of acute respiratory distress syndrome in patients with AKI stage 1, it's obvious the more fluid you give, the more likely you are to develop acute respiratory distress syndrome. It makes sense. And if you look at fluid accumulation and survival in intensive care unit, comparing patients with no fluid overload to patients with fluid overload, and you look at their survival, you find that patients with fluid overload, whether they are on dialysis or not on dialysis, had better survival on the ITU compared to patient with no fluid overload compared to fluid overload. So when you read this, it might not just be how much fluid you give them, because clinically fluid overload may also be a reflection of underlying cardiovascular disease, may also be a reflection of underlying heart failure, low ejection fraction, and so on. So you may have confounders by indication, meaning that these patients have better cardiac function than these patients. But in general, the more you load, the less good the outcome. So fluid accumulation in intensive care unit may be associated with adverse outcomes. And be careful that association doesn't mean causality. So when we say association, it means those who were fluid overloaded had worse outcomes. It does not mean that the fact that you overloaded them led to worse outcomes. So as I said, it could be underlying heart failure explaining both. When to start renal replacement therapy? Do you start early or do you start late? And in some studies, 2 randomized controlled studies, 106 patient in one and 28, which again shows you that the 28 will be clearly too small a sample and greatly underpowered. There was no significant difference in outcomes. Whether you start early probably meant an estimated GFR of between 10 and 15, dialyzing the patient early and putting him on renal on CRRT compared to less than 10, and also early start defined by oliguria for more than 6 hours or less. And again, there was no difference at all in survival whether you start early or late. But having said all that, I think your criteria for treating renal replacement therapy for a patient with acute kidney injury have to be clinical and not biochemical. There's no doubt about it. Anuria, the patient is anuric for more than 6 hours, and you tried everything we said you could or you could not try. Fluid challenge, furosemide, which we know doesn't work, but you may want to use it. Hyperkalemia, severe metabolic acidosis like the one we saw yesterday, who had a creatinine of 13 and a carbon dioxide of 7. This would be an indication. Pulmonary edema, somebody was talking about high urea, I think it was Gawad this morning compared to creatinine. Very often high urea may also be a sign, for instance, in preeclampsia of severe ischemia, and therefore you get more urea reabsorption and less fractional excretion of urea. But this is really the indication. And you cannot have guidelines as to when you start dialyzing somebody with acute kidney injury. You just dialyze them when you feel confident.
All right. Can I just ask you here, when you see a patient following him, and creatinine is increasing day by day, 2, 3, 4, 5, 6, 8, 12, whatever, and there is no other clinical indication for dialysis except he is not polyuric, he is anuric or oliguric. Potassium is 4.9 and pH is easily manageable by bicarbonate.
You can therefore wait if there's no other indication.
Right.
I used to tell 10 years ago the residents, if you think the patient will need dialysis tomorrow morning, don't go home tonight without starting dialysis. Because I don't want to come tomorrow morning and find that he's dead or he's been transferred to the ITU.
Right.
Because he had
Have you applied this on
That's what I used to say, but the evidence and the data show in that type of patient you describe, who's not fluid overloaded, who is not hyperkalemic, who's not severely acidotic, you can wait.
Wait for what?
Wait for him to recover without dialysis.
Right.
But that's what you're doing. You're correcting the acidosis, you're giving him fluid, you're treating his infection, whatever you're treating.
I would do that if he started to pass fluid. If there is any marker or anything, tell me that the patient is gonna recover.
Yeah.
But if he's not recovering, then I'm waiting for him to develop some life-threatening problem.
Exactly. That's why anuria. No, you have to assume that he's not anuric or oliguric.
No, I'm saying that he's anuric or oliguric.
Then dialyze him the sooner the better. Yeah, that's the first two here. Severe oliguria and anuria. Yeah. So oliguria is less than 400, anuria is less than 150. So they call severe oliguria less than 200 over 12 hours. But yes, if he is oliguric, then don't wait for him to have pulmonary edema before you dialyze him. Because you could come the following morning, somebody left a drip, as it happens, with 2 liters overnight, and you come at 4 o'clock in the morning because the patient...
I've seen many cases of just sudden death without any explanation.
And you will be in court, and you will have a medical legal case in England on your back if you didn't dialyze him and he was oliguric and the creatinine was going up every day. No, I assume he wasn't oliguric. So these 2 randomized studies are too small to be conclusive, but they are proof of concept. Proof of concept means that it gives you a hypothesis that early may not be better than late, but you will need a much larger study, prospective, randomized, to be able. One message about acute kidney injury I think we can all take home. It's almost impossible to do a randomized controlled trial on patient with acute kidney injury because there's no 2 patients alike. And they're so heterogeneous, so all the studies that I'm showing you are either no difference or negative. So difficult. Right, so no difference. In that study, 106 patients, post-cardiac surgery between early start and late start. Is there any difference between intermittent hemodialysis, so 3 times, 4 times a week on the ITU, compared to continuous renal replacement therapy, which is CVVH? So CVVH continuous over 24 hours for all the time, compared to intermittent every 2 days, depending on the indication, every 3 days, and so on. And most studies, and I'll show you a meta-analysis, show no difference in outcomes between intermittent and continuous. And again, there are different dialysis modalities. You can dialyze every other day, hemodialysis. You can do continuous CVVH. You can do SLED, which will be slow and daily, but usually at night time, extended dialysis. And again, I think at the end of the day, you have to individualize the treatment to the patient in front of you. If the patient is hemodynamically compromised, he may be happier with slow, gentle CVVH. If the patient has to go for all sorts of tests during the day, he may be better off with 12 hours every night of slow, extended dialysis. Or if the patient is well, you have hemodialysis facilities and you can dialyze him 3 times a week. There's no need for anything
And
else.
according to experience, the capabilities of urine as well.
Say it again?
According to your capabilities, your experience and the capabilities of the unit.
Yes, very much so. So all acute kidney injuries, the really sick ones in the UK, are managed in the ITU and are managed by intensivists, not nephrologists. They only call us when the patient is ready to be discharged and he's still dialysis dependent.
Or if there is complication.
Or there is complication. And the nurses on the intensive care units are very expert in CVVH and have very little experience in intermittent hemodialysis or SLED. So they tend to do CVVH. And these are a meta-analysis of all the studies comparing intermittent hemodialysis to CRRT, and most of them not significant, not significant, not significant. There's no really significant difference. How much CVVH? There's 2 studies, the Renal and the next one, showing high versus low intensity renal ultrafiltration, basically. So 40 ml per kilogram per hour compared to 25 ml per kilogram per hour of CVVH, continuous venous hemofiltration. And again, there was no difference in morbidity, and there was no difference, as on this slide, in death and mortality. And this, the first one was the Renal, this was the ATN, published in the New England Journal of Medicine, and again, no difference at all. And again, when you look at meta-analysis, including these 2 studies, not significant, not significant, not significant.
The financial cost is a lot between CVH and hemodialysis.
The what?
Financial
Cost. CVVH?
Yeah, it costs here something like 1,000, 1,500 a day, while hemodialysis costs something like 200 a day. So 7 times more.
And the problem with CVVH is you also get a lot of clotting of the circuits. You get a lot of changing of the whole circuits, problems with anticoagulation. They tend to use heparin, then they get problems with clotting with heparin. They switch to prostacyclin. So, but as you said, at the end of the day, all this doesn't matter more than the experience of the staff who deals with one or the other modality of renal replacement therapy. This is the study comparing ultrafiltration, I was mentioning, to diuretics in cardiorenal failure, which is mainly heart failure. 180 patients randomized. So it was a randomized controlled trial. It was a prospective trial comparing increasing dose of diuretics to ultrafiltration, and the primary endpoint was changes in serum creatinine and urine. And if you look at weight gain or weight loss, the 2 were equally effective in removing fluid. And there was no difference when you looked at serum creatinine, changes from baseline. One is diuretic and one is ultrafiltration. Ultrafiltration is red, pharmacology and diuretic therapy, mostly intravenous, was blue, and baseline versus weight loss, or baseline creatinine versus end of study creatinine, there was no difference. So they were equally effective in terms of weight loss, and they were equally effective in terms of kidney function, but then it's easier to give an infusion of diuretic than to ultrafiltrate a patient in that particular study.
no difference. Provided the patient responds, not all patient responds.
No, we were talking about this with Ahmed. I think with diuretics, you need the patient to be reasonably hemodynamically stable. You need the patient to have a reasonable cardiac output and therefore systolic blood pressure. You need the kidneys to be reasonably well perfused. If you've got low blood pressure, hyperperfused kidneys, ischemic kidneys, the diuretics will not work. And again, there's so much heterogeneity in these studies, it's difficult, and you have to personalize it. So system management is what Alain was talking about, and the fact that when the UK surveyed all the acute kidney injury management, they found that 70% of cases in the UK had a substandard care. But this is because AKI predominantly occurs obviously in sick patients. In the UK, acute kidney injury is increasing because people are getting older and they have more and more intervention, PTCA and others, at the age of 70, 80 and even 85. So you start getting more and more acute kidney injury, but you also get a lot of mortality. AKI is predominantly managed by non-nephrologists, and that is the main issue. In non-nephrology hospitals where there's no nephrology at all, improving AKI management needs to target non-nephrologists again. And this was interesting if we quickly go through the different endpoints, but each one on this side of the line of neutrality is worst outcome. So if the dot and the standard deviation doesn't touch the line of neutrality, it means that the outcome was worse in every respect. So the first one was sepsis, non-renal outcomes, pneumonia, myocardial infarction, heart failure, etc. Larger hospital, smaller hospital, medium hospital, larger hospital. And you always had a trend to better outcome in the larger hospital and worse outcome in the smaller hospital. You could easily have had the opposite. And in a lot of studies, larger teaching hospitals have the worst outcomes. The hospital where most experts are very often have the worst outcome. Why do you think that is the case?
Type of patients.
They get the most difficult patients, they are tertiary referrals, and then they get the most complicated cases where the small hospital will refer him to the large hospital. So you can have it either way. And when they looked at acute kidney injury by hospital size, usually you have more problems on weekends than on weekdays in England, for the simple reason that on weekends the staff may be slightly less, on weekends senior management may be less, and also you have more problems at night than during the day. So now they have hospital at night and night hospital where the consultants sleep at home and the whole at the hospital and the whole team sleeps in the hospital. So the nighttime team and the staffing at night should be equal to the staffing during the day, and also weekend and weekdays. But again, smaller hospitals, larger hospitals, and the outcome there is mortality and mortality as well. But basically, more mortality in relation to acute kidney injury outcomes in small hospitals compared to large hospitals. So hospital size, hospital staffing, timing of the day, timing of the week may also be important. I think it was Alain who also mentioned, or Hussein, electronic reporting. So how to improve services in non-nephrologists setup, beside education, beside increasing awareness, is work closer with the laboratories. I think nephrologists work close with pathologists on renal biopsy, but we don't work close enough with biochemistry labs and so on. So when I ask you how do you measure serum creatinine, you don't know. When I ask you what are the different methods to measure PTH, you don't know, and things like this. So you need to know these things, and therefore, if you get your laboratory to have an automated and automatic reporting system, which automatically tell the geriatrician, tell the heart surgeon, tell the pediatrician, careful, there is an increase of more than 1.5% and so on. The patient may have AKI stage 1, refer him to a nephrologist and so on. Something else we were just talking about, comparing biomarkers and following Saddam's lecture. For stage 1, you need 50% increase in serum creatinine. 50%. So the easiest biomarker would be to make the first stage 20%, 25%. And you might find that 25% increase in serum creatinine is as good as all your NGALs and KIMs and so on. And I'm not sure why 50%. Once you know your lab variation, let's say 10%, then anything above this should automatically trigger a question mark or an alarm system or a warning that there may be something. You repeat it, as Hassan said, 3 times, and if it's still 30% or 25% higher than the baseline, then you may want to. So I suspect one thing that might change in the future is 1.5, i.e. 50% increase to perhaps 30%. So to conclude, AKI is a risk factor for CKD, which I said earlier on. AKI prognosis are still very poor, meaning 50% no better than 50 years ago, but the population has changed. There used to be young people, used to be infection, obstetrics and others. Now they're old people with comorbidities and cardiovascular disease. Saline with low chloride content remains the fluid replacement of choice. There's no indication at all to use starch. Use albumin as indicated. It is not harmful. Dialysis dose or mortality has little impact on outcomes, which gives you, therefore, the liberty to choose the best modality that suits the patient, that suits your expertise, and that suits your finances as well as your staffing. You'll hear more and more about toolkits and care bundles and all this to early diagnosis of AKI and biomarkers. There are no treatments that have shown to improve outcomes, including survival of AKI, especially in intensive care units, beyond good clinical care. So I think that is the message, simply due to the fact that AKI nowadays are very sick patients with a lot of comorbidities, and it's very difficult to have a proper trial. That's it.
Thank you.
Thank you.
May I ask just a question, and I think somebody might consider it a silly question. When you see a patient in your hospital and his creatinine gone up from 1 to 1.5, what would you do? I go and examine the patient, examine the drugs and everything is okay. And I go and make an ultrasound, ask for ultrasound, the urine analysis, other biochemistry for him, and everything was okay. So,
I mean, you will repeat the test.
yeah, I will do it tomorrow.
You will do it tomorrow, and
Right,
if
I see.
tomorrow is 1.8,
Yeah, then
I would worry.
yeah, I would worry. But after I worry, what would I do?
So this is a patient in hospital for some reason.
Yeah,
So we have to figure out why he's in hospital. And he's not on any nephrotoxic drug.
yeah.
He's not on any drug that interferes with tubular secretion of creatinine like trimethoprim or cimetidine. So no reason at all, and the urine sediment is inactive, there's no red cells.
Most of these patients are coming with infection somewhere in the body. I mean, chest infection, abscess, whatever.
I would treat the underlying problem.
Yeah.
And then repeat the creatinine, but I wouldn't do much more.
Just what I do is I keep an eye on it.
Yeah.
There's no active thing to do here.
Yeah, but again, we shouldn't underestimate how important is active, close monitoring.
Right.
And I think that is a treatment. We also shouldn't underestimate how important it is to stop drugs, not always to add drugs.
Right.
And there's very often nephrotoxic drugs, antibiotics, all sorts.
So I would review the file and see any unnecessary drug to cross it off.
Yeah.
And review the flow chart and see if he's balanced fluid-wise. I'll go and review his clinical for manifestations of dehydration or whatever.
And if he's diabetic and you suspect infection, even if he's apyrexial, we can always do some cultures.
Right.
I mean, the white cell count may be normal as well. But yes.
But this is a usual practice for everyone, even if the creatinine is not increased.
And then I usually find that the geriatrician have increased the dose of ramipril or something.
Right.
Which is another common reason why you
I would stop ramipril when I find...
Stop it,
I would stop it if I find increased creatinine.
Yeah.
I would go straight away. Stop any acid inhibitor.
Yeah, and you will find that the creatinine 3 days later may come down again. Yeah.
Sometimes I find these cases related to hyperuricemia.
Yeah. I'm not convinced that hyperuricemia causes the rise in creatinine. I think the hyperuricemia tells you that the kidney is ischemic.
Yeah, our kidney is decreasing.
Yeah. I don't believe the hyperuricemia causing kidney dysfunction. I think hyperuricemia is simply a marker of all people's renal ischemia. Therefore, they reabsorb and don't secrete the uric acid, and like in preeclampsia, and doesn't tell you any more than that.
Right. So if you see a serum uric acid 10 or more.
Serum uric acid 10 or more in the absence of declining kidney function, in the absence of symptoms of gout, we usually don't treat. But some people do. Some people do, yes.
I think there is emerging evidence about the benefit of lowering uric acid.
Yeah.
But
just to go back to the old type of patient, before we come to uric acid, a lot of old people, as we said, have a creatinine of 1.5 and then goes up to 2 after many years, goes up to 2.5. And these may be kidney attacks due to atherosclerosis, cholesterol embolization, glomerulosclerosis. No?
You remember the essay we had on all our
hyperuricemia.
Hyperuricemia. And this is a very hugely debate area. Simply, there's no known function of uric acid. We do not know exactly what is the function of uric acid.
Some people advocate an antioxidant properties.
It exists in body. We do not know how to assess its function. We cannot produce uric acid in animal models because they have a further enzymatic pathways that are not present in humans, so that any animal study in uric acid is biased from the start, and that's very difficult to have no experimental model. And then when it comes to the uric acid and its correlation with disease, cardiologists are more convinced that it's somehow related to endothelial dysfunction, and somehow. And they pretend that lowering uric acid will improve at least systolic blood pressure, and this is proved from observational trials mainly, but not some evidence. And the other issue is that it is the drug, not the lowering of the level. Because it was found in studies that use xanthine oxidase inhibitors per se, as they improve the endothelial dysfunction somehow, are beneficial. Whereas when you use another drug, say like febuxostat or whatever you lower the level, you do not have benefits in the trials. So that was proposed, maybe it's the drug that helps a little bit. But this is a very huge area of debate.
Allopurinol is an interesting one because it has other properties than lowering uric acid, including lowering blood pressure.
Yes. And in graft function, there is some report that it can improve or prevent ischemic reperfusion. Somehow, there is no solid evidence, but it's common practice. Before transplantation, somehow you give patient allopurinol, 1 dose or 2 doses for the donor and the recipient. I think it's a common practice in Egypt at least. Not that substantiated by evidence.
I think the kidney guidelines, this issue, summarize what you said. They don't support, they neither support, neither refuse using hydroxyethyl therapy for the retarding of chronic disease.
Yes, so
this is
very
always there is a great.
But I think to go back to acute kidney injury, these are increasingly sick patients, increasingly multiple comorbidities, increasingly older patients, and I think the best care you can offer them is close monitoring and timely intervention. Now, timely can be
by biomarkers.
Yeah. Measure and count.
We should be careful about the toxicities and side effects of allopurinol.
Allopurinol, yeah.
Skin rash.
Yeah.
I witnessed the 2 cases of toxic dermal
Yeah.
nephritis.
When I use it myself, when I started using it, I licked the tablet first, and I had a quarter tablet because I was very frightened of the side effects.
And you have to lower the dose and adjust it to the renal requirement as well.
One area that we didn't cover in the CME here is the biopsy.
Yeah, that's an important one. So the role of renal biopsy in a patient with acute kidney injury and the role of kidney biopsy in acute kidney injury can be very important. That's why I like the pre-renal, renal, and post-renal. It's so simple. I'm not going to say stage 1, stage 3, stage 2.5. Pre-renal, you wouldn't biopsy. Post-renal, you would relieve obstruction. And then you've got the renal, who could be a lot of acute interstitial nephritis, a lot of omeprazole and zoprazole PPI-induced interstitial nephritis, antibiotics-induced. And unless you biopsy them, you will not know. But if you biopsy them, you can treat them as we've seen yesterday.
And you don't wait until the patient goes to a certain stage. When you decide to biopsy, you might biopsy him at any stage.
Yeah. If you don't know why your patient's creatinine is going up, biopsy him.
So we put the indication for doing the biopsy. If it is unknown etiology, we do biopsy. If urine refers to interstitial nephritis or renal nephritis by the presence of cell cells, proteinuria, all these are indication for.
There's a lot of study. The bigger one was by Kim Soles in 1975 or 76. Thousands of patients in France who were biopsied, and you get a lot of surprises. You get a lot of acute interstitial nephritis. Obviously, you get a lot of ATN, but you get surprises.
The presence of systemic disease, another indication for biopsy.
You wouldn't get glomerulonephritis because the urine sediment would have told you. But you can get interstitial disease. And so many drugs cause acute interstitial nephritis. We don't look for urine eosinophils in the urine because it's not done routinely. I know it's in all the textbooks, but we don't do it. Do you do it in Mansoura?
We try to do that, but no one can do it.
Yeah, we don't do it.
It's not easy.
And then the evidence that you find interstitial nephritis wouldn't support that much given steroids. So that in the first place, you just come back to the therapeutic nihilism and just stop drugs.
Yeah.
So that I was discussing with Dr. Hussein that we are, as nephrologists, most of the times when consulted, we just stop things. We do not add plans. We tell them, okay, stop the antibiotics, stop the ACE inhibitor, anticoagulation may be harmful, and decrease distillate fluid, that's it. You are blocking the plan. That's why we are not consulted anymore.
I was just about to say that we are very different from non-nephrologists. Non-nephrologists keep adding drugs. A good nephrologist, stop. A nephrologist who wants to keep his clients, add. Because to keep I mean, if you tell a patient who comes in a private setting, if somebody comes in a private setting to you having seen 6 nephrologists and you tell him your treatment is perfect, I'm not changing anything, he'll never come back to you.
That's true.
That's true. So you have to do something, but that's not nephrology, that's business. أنا ابتدى يعرف تفاصيل البيزنس. Okay, thank you.
Thank you very much. Yeah. We have a